All right, good afternoon, everyone. Welcome to this session, hot topic number 2 session, radiology versus endocrinology versus surgery. I would say guidelines or sort of impressions is what we'll be talking about today. I'm Brian Haugen from the University of Colorado, and we have a wonderful panel today. Starting on the far side, we have Dr. Yasuhiro Ito, the Director of Clinical Trial Management Center at Kuma Hospital in Kobe, Japan. Next to him is Dr. Martin Brzezinski, the Professor of Surgery, and I'm going to mispronounce this probably, Jagiellonian University in Krakow, Poland. Next to him is Dr. Mary Frades, who's Associate Professor of Radiology at Harvard, Brigham and Women's Hospital, and also co-author of the ACR TIRADS, which we'll talk about a little bit today. And then next to her, obviously I think known to everyone, is Dr. Greg Randolph, Professor of Otolaryngology, Head and Neck Surgery, and also the Claire and John Bertucci Endowed Chair in Thyroid Surgical Oncology at Harvard and Mass Eye and Ear Infirmary. And I believe Dr. Freeman will not be able to join us. He's doing another session.
That's correct.
So we have this august group. And I was talking with Dr. Frades ahead of time. And so she's going to represent radiology. I'll try to represent endocrine. And then we have our 3 very strong surgeons who can give their representation here.
Surgically weighted,
So,
right from
and we'll do this in a
the
case-based
Very
format.
biased.
So this is the first patient who's a 52-year-old female who had a 3.9 centimeter right asymptomatic thyroid nodule that was noted, and no abnormal neck lymph nodes were seen. And this is just 2 images of her right-sided thyroid nodule. And I would ask Mary to comment just on your impressions of this nodule.
Okay, it looks like it is a pretty good size nodule that is mostly solid. It has a few little cystic areas in it. It is a little hard to see the normal thyroid around there, but it looks like it's an isoechoic lesion. I suppose it might be a little bit hyper, but it's probably an isoechoic lesion. And it's also hard to know whether there are a few tiny punctate speckles in there or not, but I think you predominantly have a mostly solid isoechoic lesion, which is pretty big. The size of it, I think, is going to guide your management from here. The vascularity, there's a little peripheral vascularity, not a lot of internal vascularity, and we have shown that the Doppler pattern is not really very helpful to differentiate benign from malignant nodules. So that's not really a very useful image to add to your management characteristics. But again, based on the 3.9 centimeter solid nodule, she's going to get an FNA at our institution. And following, I think, any of the guidelines based on size alone.
And what's the use of either RealTime when you're doing it in the radiology area, or at our institution, which is nice, is they do produce cine loops, so loops that we can look at real time. When you're saying there could be some bright internal reflectors, how useful is real-time cine loop versus these still images?
So it's a trade-off, you know, when you're sitting and looking at images all day, it takes longer to look at a cine loop than it does to look at a static image. So if you're trying to be really fast and really efficient, it's much easier if your sonographer or your tech just gives you 15 static images and you can just look at them and be done. But the clip is imperative because you're doing 2 things. First off, you're looking to make sure that you've gotten a representative image. There could be a whole bunch of calcifications in this nodule that you didn't get a picture of, which you won't know until you sweep through. And you also want to look at the margins that we just saw in the prior session about the invasion of the trachea and invasion of the esophagus and all of that, looking at the surface of the thyroid and making sure that the nodule has not broken through the surface of the thyroid, and all of that can really only be established with a cine clip. We scan all our patients. We follow our sonographers into the room and rescan all of our thyroid nodules. That's not something that you're going to get probably outside of a radiology department.
Great, thank you.
One for radiology.
Yeah. And so I guess we talk about these pictures and sonographic patterns, and one thing I wanted to obviously bring forward is sort of what came out in the American Thyroid Association guidelines with sonographic patterns, rather than just looking at individual features, but trying to make patterns. And what we did was looked at the high suspicion malignancy, which is, again, usually a hypoechoic nodule that has some other concerning feature, such as irregular margins, these internal hyperechoic features that might be microcalcifications and a taller than wide shape. Then there's the intermediate suspicion malignancy risk, 10 to 20% thought to be in the literature. This is a hypoechoic solid nodule that does not have these other features. A low suspicion malignancy risk, which is this potentially this nodule that is isoechoic or possibly hyperechoic, again, not having these other concerning features. Very low suspicion, which is that classic spongiform nodule or these different cystic type of nodules that we see. And then finally, a benign, which is a purely cystic nodule. And the idea here was that a lot of these patterns go together, and could you do a pattern recognition rather than have to look at and pick each individual feature? And that's how this was developed for the American Thyroid Association guidelines. And this just then is the figure that shows some examples. And many of us have this laminated up by our ultrasound machine so we can kind of look and say, what suspicion category is this in? And then the recommendation sort of when to consider a fine needle aspiration biopsy. And I guess, so again, coming back, Mary, is, I mean, do you use this? We'll come to TIRADS in a minute, but what's your feeling about the use of something like this, the ease or the difficulty of use of a system like this?
It's an interesting question because I think, and I've heard this at the meeting for the past 2 days, the whole concept of how we're going to approach thyroid nodules has changed, I think, in the past 10 years. So 10 years ago at the Brigham, we biopsied every nodule over 10 millimeters in size, period, end of discussion, regardless of its sonographic appearance, regardless of the presence of, we biopsied 100% of the nodules over 10 millimeters in size. And it's taken a lot, and that contributed to the world increase in thyroid cancer, right? Because if you see it, you can biopsy it, you can find the cancers. And now we're seeing this sort of sea change to maybe we just want to super select and only biopsy cancers so that our FNA yield is higher for cancers. But I think you want to go even farther and say, okay, maybe we just want our FNA yield to be the high-risk cancers and not the low-risk cancers. And so the pattern recognition is great for finding cancers, but I don't think it's going to help us find what type of cancer it is. I think we're still going to have to do the FNA and start doing the genomic testing and then give us some concept of management, to help with management. So I think the most important thing here is the high-risk category, that your top 70 to 90% category. The rest of the categories, it's nice, but you're just actually not that good. You're not quite good enough in the intermediate and low-risk categories to just stop FNAing because they're in those two categories.
No, and I agree, and we've had people ask about, when you look at this, you say the high rate, again, just by sonographic features alone is approximately 70 to 90%, but then it drops down to 10 to 20% in the intermediate. So you really have a big drop from your high risk to these others. And as we discussed, this patient likely is in this low risk category, but obviously is bigger than 1.5 centimeters. So as Mary said, we would biopsy this. But of course now there are many systems, and this is just another more recent system that has been published that Dr. Frades was part of, this thyroid imaging reporting and data system, TIRADS. And then this just shows the TIRADS here, the different categories, and instead of just a general pattern recognition, what's done is they're scoring. And then it puts them into these various risk categories you see below, from green, which I guess is good, to red, which is more worrisome. What can you give us kind of an indication of sort of this and how it's used?
So the ACR TIRADS goal was actually to decrease the number of FNAs that get done in the department. So rather than the goal of prior guidelines, the SRU guidelines that I was part of, or many of the other guidelines across the world, to increase your yield so that you have more positive FNAs, the goal for from the ACR thyroids was to decrease the total number of FNAs and to be able to move a lot of nodules into you don't need a biopsy and you don't need to come back and you don't need to be followed, to decrease the number of thyroid ultrasounds and decrease the number of FNAs. So what they've done is that even in the mildly suspicious categories, FNAs are not recommended until the nodule's over 2.5 centimeters, taking into account the aggressive nature of thyroid cancer over a certain size and trying to, again, find the low risk, be able to ignore the low risk cancers, and to not even follow nodules if they're under 15 millimeters and they're not high risk. So it's attempting to give a management strategy. Now, I haven't been using it for very long. It was only published in the spring. I think it was in April. But you can print out, I brought one up for me now, you can print out this handout, and it's really incredibly easy to say, okay, it's solid, it's hypoechoic, it's not taller than wide, and then you find yourself in this corner, and anything under 2.5 centimeters, you just move on. And it really just speeds everything up. You can put a number, BI-RADS, breast imaging radiology diagnostic systems, has been used for years, and the goal there was that a patient who had a BI-RADS on a mammogram of a 2 or a 3 could then go somewhere else in the United States with that report, and the radiologists in California would know what the radiologists in Boston said about the left breast upper quadrant. And that's our goal here. When the patient moves from place to place, if you have a TI-RADS number 3 in your left upper lobe, you know how it's been established somewhere else, and the patient can come along with that analysis and move from place to place as well.
Good, thank you. And I did my own estimate of this. I don't know if you agree, but I gave this one 3 points. And so that would put it in this mildly suspicious category, and it is over 2.5 centimeters. So as we talked about at the beginning, whichever system you use, then you'd be able to say, okay, this person probably should have a fine needle aspiration biopsy. I guess, do any of our surgeons disagree and think this patient should not have a fine needle aspiration biopsy?
No, I think it's obligatory in this case.
Of course, it's indication. It's indicative.
So the patient did have a fine needle aspiration biopsy, and it was read as suspicious for papillary thyroid cancer, that Bethesda 5 category, not the Bethesda 6 papillary thyroid carcinoma in this patient. And then this again just shows those Bethesda categories as benign, malignant, non-diagnostic, and this kind of suspicious or indeterminate category, we can see, at least by this report, has a fairly high risk of being cancer. And generally, I think, and that's where I'd like to, I guess, bring our surgeons in, maybe first with Greg, in that, does it make a difference to you if it's a Bethesda 5 or a Bethesda 6 on how you're going to approach a patient?
It makes a difference to me. It makes not a difference to my endocrinologist. So their surgical aggression exceeds my own. I just like, the key point I think I would say for offering surgery or discussing surgery with a patient with a suspicious aspirate is to just say that even the anxiety of the word cancer being said doesn't make 70% 100%, because you want to make sure that they understand that it's a likelihood, and to plan a total thyroidectomy because of that overwhelming likelihood is very reasonable, but it is not 100%. This softens the blow a little bit when you've done a total thyroidectomy, perhaps had a complication in that total thyroidectomy, and the path report comes back benign. You're just sharing the reality. It's very easy for that to be run roughshod over, because patients, when they initially see their endocrinologist get a biopsy, they often will come saying, I have cancer, with a suspicious aspirate, and it's likely that they do, but it isn't a foregone conclusion. And I think that little difference of meaning just needs to be, a moment needs to be taken to explain that to them, because those that would really favor a less aggressive approach, given that a lobectomy, even if it was a cancer, a lobectomy may be appropriate in certain circumstances, and I think Brian will get to that, that you just want to have spent a little time with the patient beforehand discussing that.
Great, thank you. And I think the other thing I wanted to bring up with this suspicious for papillary thyroid cancer is, is something that some of the work that we did with the gene expression classifier, I think we found things more than looking at molecular markers, but as far as cytopathology and even histopathology, but in this case, cytopathology, how reproducible is this? And one thing we had the advantage of when we did that is there were 49 centers in this study, and so there was a local cytopathologist, and we had 3 expert central cytopathologists who blindly overread all of these as well. And what I just want to point out, I guess, number one in the middle is the local cytopathologist called it follicular or Hürthle cell neoplasm, and you can see that almost half were confirmed by the central cytopathologist below in that pie chart. But others were moved to benign in the green, even a few malignants in the red. So there was some differences in reading this, but this is a fairly stable category. I think the 2 that are the least stable are the atypical, which is that AUS FLUS category that's being changed in the next Bethesda iteration somewhat. And then what we're talking about here, this suspicious for malignancy, which I want to point out, is that when it was sent to central cytopathology, almost half of them were then recategorized as malignant. So more, and I think what happens is if you have a more confident cytopathologist, you have less calls of suspicious for malignancy, less calls of atypia, and more definitive either benign or malignant or this follicular neoplasm category. So that's one thing we can always think about is we can always have another cytopathologist potentially look at it to see if they can help us with that. I just wanted to make that point. So coming back to this patient with this suspicious for papillary, I guess I think we would all agree that this patient should have surgery. Martin, would you do other pre-op imaging at this time? What type of surgery would you recommend?
Well, actually, I'm also interested about the patient's approach to this asymptomatic term, because as soon as the patient knows that there is an almost 4 centimeter tumor, probably most of ladies will tell you that there is some compression that they feel that they are not very comfortable, and actually that they realize just after the ultrasound diagnosis. The other thing is the contralateral lobe, how it looks like. In Europe, we deal with quite a lot of patients with multinodular goiter, which may influence our surgical decisions, whether we go for total thyroidectomy or unilateral lobectomy. So it's also important to know the contralateral lobe, if there are any lesions, suspicions or not. And of course, we should not focus on thyroid ultrasound only, but we should perform neck ultrasound, including the lymph nodes.
And maybe speak a little closer to the microphone so they can hear you
the
in the
lymph
back.
node status is extremely important, so we should not only focus on the thyroid ultrasound, but the neck ultrasound, including the lymph node status in the patient, which may also influence our decision.
No, good. Yeah, thank you. And again, this patient seemed to be still asymptomatic, even knowing, I agree, sometimes when you say you have a large thyroid nodule, they say, yes, I do maybe have some symptoms. The other lobe was normal, really showed no lesions and no abnormal lymph nodes seen on the comprehensive neck ultrasound. Recommended in the guidelines, and what many of us now do is when we evaluate a thyroid nodule, the neck is also evaluated when we do that. Yes, you're here.
Yeah, in my opinion, it is very important to tell the patient that you may have cancer, but your nodule may not be cancer before operation. You have to tell the patient. And in my opinion, I perform only thyroidectomy because it is only suspicious. It is not the other. But with the 6, we perform total thyroidectomy at the time. But with 5, the 30% maybe benign. So we perform the normal surgery, so hemithyroidectomy.
And if the patient said to you, I'll do whatever you want, I guess we heard what Yasuhiro said about that, Marcin. What would you, if the patient said, I'll do whatever you recommend, what would you recommend?
I recommend hemithyroidectomy. Yeah.
Marcin?
Well, actually, in this particular patient, perhaps it would be reasonable at our healthcare circumstances to perform lobectomy and send it for frozen section.
Greg?
I just want to, I think as a surgeon, it's probably best to try and not operate as much as you can. And when you operate, try and do as little as possible. I think that's the best recipe for success. Obviously, you must meet the goals that are presented with the patient, but a patient like this, say if we had a biopsy that was completely benign and they just wanted to take it out because it's benign, I've seen many surgeons then take out the other lobe because there was like a 3 or 7 millimeter nodule, which wouldn't even get a handshake if they came in with just that. So why is that being operated on just because it has proximity to the index lesion? I mean, should proximity be a surgical indication? I think each lobe is a separate room that you can either knock over the statue in or not, and so you just want to have business in each of those rooms. So each of those lobes is a separate decision, and I think it should be really premeditated, and you should be forced to go into that second room.
Thank you.
My opinion.
And so one thing I thought Greg would maybe bring up, I think he's a big fan of CT scan, especially for malignancy, right, for assessing the neck. And one thing I think Greg had been instrumental in working on, one of our recommendations, is the use of preoperative cross-sectional imaging. Now, obviously, this patient being a suspicious for papillary, nothing else abnormal, most of us likely would not do other types of imaging prior to surgery. But if you have a patient who has suspicion for extrathyroidal extension, grossly abnormal lymph nodes, this is one thing I think my surgical colleagues have taught me, that we need to think more about good cross-sectional imaging, either with CT or MR. We tend to rely on CT more for these patients who are at suspicion for advanced disease, but that's not this patient. So this question of thyroidectomy or lobectomy, and just again, I think people know that in the 2009 American Thyroid Association guidelines, it was thyroidectomy over 1 centimeter in all. And this was largely driven by this Bilimoria study. And then with the 2015 iteration, there are a number of articles that really came up from database studies. These are not prospective randomized trials, but from database studies that showed, depending upon the metrics you looked at, that a lobectomy up to a patient with a 4 centimeter malignancy in the correctly selected patients, a lobectomy had the similar outcomes to a thyroidectomy, which led us to this recommendation that a thyroidectomy or a lobectomy could be done in the patient with malignancy, a strong recommendation which we felt was based on moderate quality evidence. And again, Yasuhiro, I think you would lean more toward, if this was a Bethesda 6 in this patient, all your patients you'd recommend a thyroidectomy?
Actually, we Japanese has our own guidelines. This falls on the intermediate risk. So the intermediate risk indicates the total thyroidectomy or lobectomy, actually. So both are okay, acceptable in Japan. But in our institution, we recommend total thyroidectomy because actually the T2 tumor has actually a little bit poorer prognosis than T1 tumor in our data. A very small difference, but significant. So in our hospital, we perform total thyroidectomy, but lobectomy is also okay. Actually.
And do you also recommend or perform ipsilateral node dissection in these in all of these patients? Remove the lymph nodes, central lymph nodes on the side of the tumor in these patients?
Yes. If Bethesda 5, we perform hematology with ipsilateral settle dissection. It's not evident. Just we habitually do so. Yeah.
And Marsan, do you?
Well, as said earlier, I would go for lobectomy and send it for further section. If it is benign, assessed as benign, I would terminate the operation at this stage. However, if it's recognized interpretively as papillary thyroid cancer, practicing in Poland, I have to go for total thyroidectomy in this particular patient because our Polish guidelines indicate that lobectomy can be considered for tumors which are recognized as PTC smaller than 1 centimeters. Our endocrinologists are pretty aggressive. Actually, they would also want me to perform prophylactic central neck dissection at the site of the tumor, and they are not very satisfied if they have the histopathology report indicating 1 node. They would prefer to have just 3, maybe 6 lymph nodes in the specimen. They feel much better and much more confident with the final diagnosis. We still use quite a lot of radioactive iodine in Poland, so that's why I cannot do anything else.
You need to please your endocrinologist.
Yeah.
Yes, sir.
Actually, in Japan, we do not perform further section because for such cases, it's very indolent. At least in our data, after hematology, the prognosis is excellent. So we do not perform conventional total thyroidectomy after the pathological examination. So there's a great difference, but yeah.
Thank you. All right, so I'd like to move on to the next patient, a 45-year-old male with an incidental 8 millimeter thyroid nodule, and I guess I'll come back to Mary to go ahead and tell us what you think about that nodule.
Well, I actually had a little trouble with the images here because I couldn't quite tell if the 8 millimeter nodule was just the very hypoechoic part inferiorly or if the central part of the lobe had an extension of it. So I had a little trouble with this, and it does have some calcifications, and it's probably taller than wide, and it is pretty hypoechoic. I don't think it's very hypoechoic, but from the radiology perspective, it's 8 millimeters. So this would go into a follow-up category from the ACR guidelines.
But sort of that high suspicion.
It is absolutely, it would fall into the high suspicion category of the ATA guidelines, but we would not do an FNA at this point. We would put the patient into follow-up if there are no abnormal lymph nodes.
Okay, and this, again, would fall under an ATA suspicious sonographic pattern, and at least when I calculated it, got 13 points on the TIRADS, so it would be highly suspicious.
But under a centimeter.
Under a centimeter,
So it would
correct.
go into a follow-up, but not an FNA. I agree. I didn't get quite to 13, but it certainly falls into the highest suspicion category, because I don't think that anybody who does ultrasound would say that's not a cancer. The question is it okay to not diagnose it right now?
Okay, yes, Greg.
Can I just say, one, I completely agree, the guidelines are very clear on that, but just two things that I think we just have to, everything that we know, everything we suspect, everything that we've proven should be just discussed with the patient honestly. Put all the data on the table. So you say this is a really small nodule, the guidelines recommend this should never hurt you, but the radiographic appearance is suggestive of a cancer, because that's what is in fact the truth. You think it's a cancer based on the x-ray. You should share that reality with the patient, because the patient may have other thoughts. It would be good to counsel the patient to be compliant with your recommendations, but you should share the raw data with the patient. And then the only other thing I'd say is that if you're walking down a pathway of observing cancers, you know, this idea of you have to make sure this is a low-risk microscopic papillary. And if you look at the Dr. Aito's work and his colleague, Dr. Miucci, it's really, you have to make sure the lesion is solidly encompassed within the lobe, and it isn't resting on the trachea or resting in the tracheoesophageal groove. So the yellow of the egg, the cancer, has to be within the white of the egg, the thyroid lobe. It can't be at the edge. And you do need an ultrasonographer, which this panel is blessed with, that is capable of making those subtle determinations. Otherwise, you can't determine that that's a safe microcarcinoma to follow. I've seen a 6 millimeter node invade the recurrent laryngeal nerve and a 7 millimeter thyroid primary invade the nerve. That's less likely with small lesions, but it does happen. So you just need ultrasonographic expertise in order to step back your treatment a little bit.
No, it's a very good point, and I think we need to get better, whether it's the radiology community, the other communities that use ultrasound, is not only to characterize the nodule, but as Greg said, also to look and see, does it look like there potentially could be invasion? Because I think with the technology, we're getting better at that, Mary, at being able to at least capture the images, and then we need the expertise of people to feel comfortable saying this doesn't look like it has posterior invasion.
You know, when people are shown cases of posterior invasion or tracheal invasion or internal jugular vein, or wherever the invasion is, the images always look like it's a pretty straightforward thing to decide. But when you're actually scanning, it can be very difficult. And you can go by proximity to the surface of the gland, but it can be really difficult to know really what the margins are. And I certainly will say to my endocrinologists and my surgeons, I don't like the edge of this one against the trachea. And I actually, even though I don't speak to my surgeons all the time, I will send an email to a surgeon and say, listen, I'm worried about the trachea in this person, or I'm worried about the far edge in this person. But I do a lot of thyroid ultrasound, and many imagers do not do.
Right.
And I agree with you, it can be very challenging.
And that communication back and forth is very important, the clinician to the ultrasonographer. But we don't need to diagnose invasion. We need to diagnose no invasion. so that that patient can then be observed.
Safely observed. So with all that said, it sounds like, Greg, you'd say this person at this point doesn't need an FNA?
I would recommend that they don't have an FNA and explain that I think they may likely have a cancer. It isn't proven, but I think the thing that will make this a shorter rather than a longer conversation is if you point to the patient at the end of all of this data exchange and say, and I want to see you back in 6 to 8 months, so that they don't feel they have a cancer and you're just cutting them loose, that you want to follow this, you want to provide care,
Right.
but you want to provide the least morbid and most appropriate care, but you want to see them back. That goes a long way, I think.
Okay. Marsan, would you recommend an FNA of this patient?
Well, actually, I would not have opportunity in the public system to have a patient like this because endocrinologists would take care before me. But of course, practicing in the private practice, that would be my consideration. In general, I can say that in the Polish guidelines, it is stated that if the ultrasound appearance of the lesion is highly suspicious, the final aspiration can be considered. And 99% of Polish endocrinologists would go for final aspiration.
And Yasuhiro, we've
Yes.
talked about this before.
Yes.
When I said we don't need to biopsy, and you said, I think you would recommend.
Yes, we do perform FNAB because if we don't, patients may come to another hospital and then the patient underwent FNAB and may undergo unnecessary surgery. Then thereafter, we had some people speak ill of us. They come to hospital or overlooked the cancer.
Oh.
So that's very unhappy both for us and patients. So we perform FNAB and tell the patient you have macro cancer, but you do not need operation. Please come to visit the hospital 6 months later.
So it
That's our strategy.
It can be a medical decision and it can be a political decision.
Sometimes it can be a family history decision, and so, but my brother had colon cancer, and that's why I'm more worried. So you have to, if they're saying, I do want a biopsy, I do want surgery, you got to sort out, okay, well, that's not unreasonable, but what is the source of this worry that you have? It may be legitimate, it may not be legitimate. It may be because their wife had breast cancer, and you got to say, okay, well, that doesn't mean this thyroid nodule should be operated on. I can understand that you'd be more worried about it psychologically, but medically, this is really to try and take a minute and sort out, like, what is it that's getting you? What's
Yes.
the thing that's motivating you? Let's take a minute and talk
I
about
agree
it.
that you don't want to send a patient out with this and say you don't need a biopsy, but they're anxious. What you'd like to do is have them at least, talk it through, answer their questions so that they can go out and not feel anxious and know that they're going to get
They're more likely
monitoring.
going to comply with your recommendations if they think you're a human, and you can have a little discussion back and forth.
Yes, a human is good. I like that. And I won't actually talk about these pieces here. So again, we saw this pattern here. Again, from the American Thyroid Association guidelines, active surveillance can be done. What it says is fine needle aspiration biopsy is not required. It does not say you cannot do it under certain circumstances. If you can't allay the patient's anxiety, if there's other issues that may come up, that's very reasonable to do. Again, through the ACR TIRADS, it says it's concordant with other guidelines in recommending against the routine biopsy of nodules smaller than a centimeter, even if they are highly suspicious. So as Mary said, this is one where we don't have to do a biopsy on this. And also we want to make sure, again, there's no evidence that we can see clinically or sonographically of extrathyroidal extension or abnormal lymph nodes. Patient age and preference may modify the decision-making, and again, we need to move into this shared decision-making, and our patients should go away not being anxious. I just want to also point out that some other guidelines, this is the ACE guidelines that say if nodules with a major diameter, 5 to 10 millimeters, are associated with suspicious ultrasound signs, consider either FNA sampling or watchful waiting. So we get, again, a lot of this same theme in our different guidance. And then this, I will defer to Dr. Ito on, but as far as saying if we do watch these, what happens? And I think you've seen this type of data many times. Do you want to comment on anything in your paper or with the age of the patient and how that may affect?
Yes, very interestingly, in contrast to clinical papillary cancer, macro cancer in all patients not likely to grow. So it is in sharp contrast to colorectal cancer. So all the patients are quite very good candidates for active surveillance. And also younger patients likely to grow, but the rescue surgery is not too late after the appearance of prevention signs. That's my comment.
Right, and I think you and others have shown that even if you delay surgery and if you do see growth or lymph nodes evolving, that when you do surgery at that time, the recurrence rate after that surgery is similar to if you had done surgery immediately. So you haven't lost an opportunity to hopefully cure or manage the cancer.
But when we perform lobectomy, the first stage, the patient may recur the lymph nodes. Then the second surgery is necessary. So we want to perform only one surgery, after the progressive signs.
Yeah.
That's our concept.
Yes. Greg, did you have?
Yeah, Dr. Miucci is in the audience, and Dr. Ito is here. The initial paper of that microcarcinomas are clinically indolent, that didn't really surprise me. We're observing microcarcinoma in nodal beds that are microscopically positive and not operated on for years and years, whether we know it or not. So it doesn't surprise me that it was stable, but this data about how the older patients were stable and the younger patients were, that was a surprise to me, because I'm thinking, weaned on ages and aims and the age-related prognostic relationship, you thought, I'm going to worry about a given lesion more in an older person than a younger person. But it makes complete sense that it's this, because if you have a 20-year-old standing in front of you with a microcarcinoma, as opposed to an 80-year-old, which lesion is likely going to be the stable one? The one that is proven by 60 additional years of indolence and clinical insignificance that it's going to be stable. So it actually makes sense, but it's a little bit turns that prognostic age kind of vibe on its head a little bit.
Yeah, clearly if you have a patient with a larger or more aggressive tumor, when they're older, they do have a worse prognosis. But for these microcarcinomas, it was very interesting to see these data.
Yes, indeed.
And this, I just want to bring up that this active surveillance for low-risk cancers, it's obviously people know this is not unique to thyroid, and this just a week ago in the New England Journal of Medicine was published, and just talking about what's known in the prostate cancer field and the breast cancer field with these small tumors, and sort of bringing thyroid into the fold as well. And I think over the years we'll maybe have more and more experience as a larger international group. I think it was led by Japan and what people have done in Japan, but as a larger group to say how can we appropriately do surveillance on these patients, and how should the surveillance be done, who should be chosen. But I just want to bring to your attention, this was just a week ago in the New England Journal, talking about active surveillance for low-risk tumors, including thyroid. Any comments on that last patient who didn't get a biopsy? All right, our third...
The patient has to come back in 6 months.
Yep. Yeah, and with what we've even recommended in the American Thyroid Association guidelines is the interval of follow-up should match that sonographic risk pattern. If you had a tumor that was a low-risk tumor, you could wait longer to maybe get a follow-up ultrasound and it sounds like by the TIRAD you might
a low-risk nodule. A low-risk nodule, not a low-risk tumor.
I'm sorry, a low-risk nodule, a small low-risk nodule, you may not have to do a follow-up, or you could do it even longer, wait 24 months. All right, so our last and third patient is a 42-year-old female who did have a thyroidectomy and a central lymph node dissection for papillary thyroid cancer. Preoperative neck ultrasound showed no abnormal lymph nodes. You see the pathology report, a 3.1 centimeter papillary carcinoma, no extrathyroidal extension. 6 out of 10 lymph nodes were involved. The largest was 10 millimeters, no extranodal extension. These are all things that we should look for in the pathology report. So this would be a T2 N1A MX, stage 1, and ATA low to intermediate risk for recurrence. Postoperatively, we like to measure a thyroglobulin. It's 0.5 with negative antibodies. This patient at this time did get 50 millicuries of radioiodine, uptake only in the thyroid bed region, nowhere else in the neck. But on a 6-month follow-up, this patient had a thyroglobulin that was still low, but very detectable at 0.8. But had these ultrasound figures, and again, Mary, I apologize for just a few rather than looking at the whole thing, but what are your thoughts on what you see? The top two are in the central neck, the bottom two are in level 3, and then the other one in the upper right is in the central neck.
So those midline low level 6 ones that's an awfully small little node. I think it's only like 4 millimeters, correct? And as opposed to the IJ chain node, which is bigger, and the IJ chain node's a little easier to see that it's an abnormal node. The first thing I would do in this instance, personally, would be go back and look at the pre-op ultrasound and see if that lymph node was there on the pre-op ultrasound and if it looked like that back then. The next conversation that we would have between the endocrinologist and the patient would be how worried we are about this lesion and how comfortable we would all be to just watch it for another 6 months and to watch the thyroglobulin and maybe not do anything. I mean, the patient just had surgery 6 months ago, and we hate to send her all the way back for 1 or maybe 2 nodes. So part of our conversation would be, we can just watch these. They're not hugely abnormal. If they change, if they grow, we'll certainly do an FNA of the IJ chain 1. We can stick 3 millimeter things for you and get into them and get you a diagnosis, but the question is, what are you going to do with that information once you get it? So,
well, I think when we got better ultrasound imaging, I know many instances where, especially in the central neck, after the thyroidectomy and even a central neck dissection was performed, we would identify these very small but maybe indeterminate lymph nodes, and our radiology colleagues were great. They'd biopsy them. I would call my surgeon and say, could you please go in and remove that 4 millimeter lymph node? And he would say to me, would you come into the operating room with me and show me where that is in that scar tissue on that patient? This is, so the neck ultrasound.
Then you stopped doing that.
And I stopped doing it. He taught me and I stopped doing it years ago. So there is this suspicious right level 3 lymph node that is 17 by 11 by 4 millimeters. The others are small indeterminates. Marcin, would you recommend a biopsy on the level 3 lymph node? Would you monitor it? What would you recommend?
Well, I think it's dependent to some extent on the endocrinological approach. So probably in our country, there would be 50% of endocrinologists who would be quite comfortable with further follow-up of these patients, regular ultrasound surveillance, but I think that another half would go for final aspiration of this lateral neck node, which is a little bit suspicious. The central neck nodes, which are too small, I think that they would only follow up.
And if I was overly eager and asked Mary to biopsy it, which she can very easily, she biopsies it and it's papillary carcinoma, and we say, boy, we need to do surgery, what would be your surgical approach in a patient like this?
Well, actually, I would call the endocrinologist what is his expectation or her expectation, and I would say that I can go for lateral neck dissection if you like, but actually I would not get back in these circumstances to the central neck.
Greg?
Yeah, so a couple of things. You notice the lymph node ratio at the first surgery was 6 out of 10, and that tells you a little bit that the risk of recurrence is fairly high in the central neck. You don't want 4 of 4 nodes positive, and also you don't want 0 of 300 nodes positive. So that 6 of 10 is a little bit implying there could be a 7th perhaps at that surgery. Also, I would send this patient to Mary and not to the first ultrasonographer, because none of those 6 central nodes, including one that was 10 millimeters, were detected. So don't send them back there, whatever you do. And I would agree with when you have a divergent array of nodal recurrent sizes, some of which are above the surgical threshold and some of which are below, the best thing I think to do is wait for this crop of vegetables to grow a little bit more so that when you do operate, you can hopefully get a more robust and complete menu. Perhaps those central neck nodes will grow, perhaps they won't, but at least you will have given another 6 months of waiting. Not that you're not going to operate, but at least you'll operate in a more mature, definitive, recurrent demonstration.
And Yasuhiro, would you recommend a biopsy of this patient or surgery?
Well, we may perform the biopsy for level 3 lymph nodes, But immediate surgery or not, it's still open question. We may follow, or we perform modified neck dissection after consulting with the patients.
And so this patient was watched, and at 12 months, the neck ultrasound was stable. This time, somebody like Mary did it, and it was really good. And it was stable. You can see the thyroglobulin maybe is a little bit higher, but still is fairly low at 1. And actually, a whole body scan was done, which was negative. So it didn't look like if this lymph node is malignant, it's not easily concentrating radioiodine, and appropriately the thyroglobulin stimulated. And I guess just, again, bringing up these lymph node features, I guess, that we're looking for, and ask sort of Mary to comment on, what features are you looking for in a lymph node and how helpful are they?
So when you're looking for metastatic thyroid cancer in the lymph nodes, I think the most helpful one is the presence of the microcalcifications. You don't get colloid in a lymph node, so there's much less confusion when you look at a lymph node. If there are speckles there, then there's a cancer there. There was a report a few years back that said that the majority of metastatic papillary cancer to lymph nodes had a cystic component, and that has not been my experience. But what I would say is if there's a cystic spot in the lymph node, it's highly likely to be papillary cancer. But I would say a very low percentage of lymph nodes have the cystic component to it. So microcalcification, cystic component, vascularity I find less helpful because I think that the abnormal vascularity tends to follow the other findings. The hyperechogenic appearance I actually think is quite good as well. You can sometimes see round white balls inside the lymph node, and you know that that lymph node is not behaving. A round shape of a lymph node is very low, has very low specificity, and you're going to have to stick a lot of nodes before you get the cancers out of those. So those in particular, when you look down in the low midline in that level 6, they're all going to be round and hypoechoic, even the ones that are benign. You don't get the long lymph node 2-to-1 ratio except for in the strap muscles. That's where the length is coming from the nodes. Anywhere else, up under the jaw, in the very midline, overlying the trachea and inferior to both lobes of the thyroid, those nodes are always round, even the benign ones. So the location is a little bit helpful there. But the ones what we look for the most are the calcifications and the cystic changes, and then I actually will say, I don't really even need a biopsy on this one. You can tell it.
Right.
Yeah.
And how about benignity features? So to say this nodule is benign, the idea of a hilum or a hilar vascular flow shape?
The shape, when you do have a lateral neck shape that goes to a point and is very long and has the beautiful hilum, that you can safely ignore those. And even the round ones, you can see the hilum in the middle of them sometimes. So any sort of oval rectangular shape is much more reassuring. But I think the most important thing to remember is that that the majority of lymph nodes in people's necks are benign. And we see people come in and it's allergy season, or they just had a cold, or they just had their tooth pulled, and you have to understand, they're sneezing, they're coughing, they're going to have a neck full of lymph nodes. And so a lot of times we'll just wait on folks because they're not going anywhere fast, and it's okay to wait and see what it does if it's not your dramatic positive node. And the other comment I'll make here, we also do pediatric thyroid cancer patients at our hospital, and I don't know what they do, but 12 to 18-year-old boys have the biggest lymph nodes in their neck that I've ever seen. And you have to be really careful knowing your patient group, whether this is normal for them or not. I say to their mothers, I don't know where he's been, but I think they're all benign because they just have enormous numbers of nodes. And so you have to dial back a little bit with lymph nodes on the follow-ups.
And how about when you do follow-up in a patient who had pretty strong lymphocytic thyroiditis in the thyroid specimen, and now trying to evaluate these plump lymph nodes?
Well, again, the Hashimoto's patient has innumerable nodes on both sides, and particularly the round ones that sort of run all along the thyroid in the midline right above the isthmus. They always have a nice little round black node, and inferior to both lobes. Every single patient with Hashimoto's is going to have 2 or 3 nodes just inferior. So those are challenging. But again, the concept of, okay, and often what I'll say to the patient is, I've got really good pictures. I know where every lymph node is in your neck. When you come back, I'll know what's changing, right? I have them all numbered and I have them all labeled. If anything changes, I will know it. So you don't worry, you come back and I'll tell you if things are happening. But you have to sort of be really thorough to be able to see a change.
Great, thank you. Any other comments from our surgical colleagues on how you assess lymph nodes and I agree in a patient like this, especially since it's like Greg said, is to allow it, I think as our surgeon one time said, mature, so that you can sort of see it declare itself and is it enlarging, and now we say, okay, it's now shown us biological features and now we can maybe do a compartment dissection. But in a person like this where it's stable, we're comfortable just watching and probably at a few 6-month intervals and then stretching it out if everything stays stable.
Yeah, I would just agree with what you said and what Mary said about the divergence of size depending on the region of the neck. So the jugular digastric nodes, whether these children are currently being immunized in the early part of their life, and that's why their mouth and nasopharynx is the source of some of those brewing bacterial infections, but Waldeyer's ring, that ring of base of tongue, nasopharynx, adenoids, and jugular digastric nodes are typically large, and I know that because every time I'm doing a younger person's neck dissection, I'm finished with what I know is the malignant nodes down in 3 and 4, and I'm yet obliged to go more north than I really want to the gigantic, sometimes, jugular digastric node, but they're typically grayish. They are friable. You grab the lower end of them to pull them down, and they break apart because they don't have the binding together of malignancy. And they can be sometimes 2 to 3 centimeters cranial caudal, so really breaking any kind of size rule, but they're flat, and at neck dissection we're kind of obliged to go there, but you can tell that they can be very, very large in the jugular digastric, that is region 2A.
And maybe to Marsan, if this, let's say, was biopsied, let's say it's in level 4, so it's down lower, it's biopsied, it's positive, that side of the neck has never had surgery. I've heard some, in general, it seems to be that you would want to do probably the anterior portion of that with, 2, 3, and 4 on that side, surgery. Some people have argued you only want to go one level above the positive node. What's your approach to a patient who has, say, a level 4 positive node? Do you do a full lateral neck dissection, limited? How do you do that?
Oh, well, actually, if it's confirmed on final aspiration or washout with thyroglobulin, we go for modified lateral neck dissection of this side, meaning 2, 3, and 4 level dissection.
And not back into level 5?
No, usually not, because we can control it with ultrasound, so there's absolutely no suspicious nodes in level 5, so we can skip it.
We had a lymph node panel yesterday, and we had, I think, 5 different surgeons who had unbelievably divergent definitions. I would say most of them, the center of the bell curve was what Marcin just discussed, but there was an incredible variability about what a full lateral neck dissection was, with the head and neck surgeons a little bit more kind of wanting to do region 2A and 5B, and others maybe willing to delete it. But I think we all have to be kind of, we want to hopefully do the full compartment, but like if it's a very scarred central neck, and you've gotten the index nodes in the lower portion of the central neck, and you dissect further up where the RLN is very scarred to the side of the trachea, and you don't have any radiographic targets, I think it's wise to scale back your planned full dissection, blended with how surgically complex is it to do that, as long as you've got the radiographic index nodes in your back pocket. So I think it's okay that there's a little heterogeneity as to what exactly these compartments are defined as.
Yasuhiro, to you.
Well, I totally agree with him. Yeah. Same opinion.
Same approach?
Yeah, same approach.
And I'll just skip this. And looking at doing a lymph node dissection, just the idea of what are your goals? If your goal is to get a stimulated now, and then this is some older literature of thyroglobulin of less than 0.5, there was a 27% chance of doing that. A thyroglobulin of less than 2 on levothyroxine was a higher rate, and obviously clinical imaging, no evidence of disease soon after the surgery, or relatively soon after the surgery, had a much higher rate of success. So I guess a lot of times when we do this surgery, it depends on what our definition of success is, whether it's radiographic, whether it's tumor marker, and how sensitive and how aggressive we are with the tumor marker measurement. So again, for a patient like this, I think it's interesting what we said in the guidelines is we started by saying if a positive result would change management. So something like this, suspicious lymph nodes, and what we say is 8 to 10 millimeters in the smallest diameter. This was 4 millimeters. And really when I went back and looked at that, a lot of that literature is if you're much smaller than that, one thing is you'll get a lot more, I think as Mary said, negative results. You get, if you're larger than 8 to 10 millimeters in the smallest diameter, you have a higher success of getting positive results. This is one of these where we did a strong recommendation, but based on low quality evidence for this. And then also, if it's smaller than that, you could consider FNA or monitoring these patients, following without a biopsy in these patients. So a patient like this, even though we see a node that's a bit suspicious, it's fairly small, and we can, in many cases, watch this patient. Any other comments from the panel on that?
I would just say, I think it's a little unfair to judge the success of surgery on TG because TG is not the doorway in. This is a structural radiographic problem, and so the correction of that structural radiographic problem should be the definition of success, not TG, especially since TG is in the 0 to 5 range where all these patients with cervical nodes doesn't really have any prognostic meaning, 0 to 5. I mean, that's all good, favorable prognosis stuff. So I think it's fair to say if you have structural recurrence after surgery or persistence after surgery, that's a failed surgery. But a TG of 2 with a negative X-ray, I'm not sure that's a fair way of determining the success of surgery. Again,
Well, that paper was written by surgeons.
a little biased, but, well, no, they're demonstrating their results. You're
Yes.
taking it as an outcome parameter. They're just demonstrating this is what happens to TG, but I just don't, I think if you're radiographically successful, you may not necessarily be biochemically successful.
Right, and can just monitor that. So that was all I really had, and I'd like to thank the panel very much for this wonderful insights, and thank you all for your attention.
Well, very nice to meet you, all right? I look forward to looking at this. Let me just